just need to install my microphone. I guess when Dominic phoned me and asked me to give a seminar on health informatics, I said I know a lot about data, I know a lot about health information, I don't know anything about informatics, so you have the wrong guy. So he took me by surprise by effectively, like you said, saying, well, George Torrance talked to me and said that you would be doing a good speak, and I know George very well, and he's a very nice person, and I respect him a lot. So it took me by the feelings there, by the sentiment, and that's why I'm here today. So if you're expecting a lot of informatics detail, this is not really the seminar. If you're expecting to know a bit about data and how do we use it to make health information, this is what I'll try to cover today. And I will cover three aspects. First, I will talk about record linkage. I will talk about invasion of privacy and public good as a result of talking about record linkage. And I will talk about the third subject, which is bringing data not on individuals, but on a subject, and trying to synthesize the information into one framework. And that will be microsimulation model. And I'll make more by example than by, I guess, detailed technical presentation. Before I start, I would like to thank Dr. Covey and Dr. Fenton for inviting me for the seminar, and I hope you will enjoy it. So let's start. So in terms of the outline, like I said, I'll do a bit of a background about health information in Canada. I'll talk about record linkage, privacy, microsimulation model, and then we'll open the floor for discussion. Detailed information is necessary for appropriate management of service delivery programs, for suitable surveillance system, for understanding and monitoring population health, for understanding the etiology of specific condition, for prevention, and for health and health services research in general. My presentation will focus mainly on information required for health and health services research, and I will not talk about management information system in the healthcare field or management information system in any detail at all. Ideally, for health research, we need information about an individual, his or her social network, his or her community, and the contact that that person may have with the healthcare system through time. Rather than to come up with a great list about what type of information we need, I thought it would be better if I just list a few research questions that could be of interest to policymakers and health researchers in general. So if we talk about health services research, I'm just here putting 4 questions. Do waiting time for procedure have an impact on the effectiveness of a specific treatment? Are there non-financial barriers to appropriate treatment? Is antibiotic resistance SES blind? SES is socioeconomic status. Are preventive services reaching those who need them most? These are all questions that are very important to policymakers, and they really would like to have answers to these questions such that appropriate program and policies can be put in place. If we look at population and occupational health, what is the nature and extent of socioeconomic disparities in mortality and morbidity in Canada? Why are some communities healthier than others? Does it depend only of the composition of the population, so the individual risk factor, or does it depend on some characteristic of the community? Which jobs are killing Canadian workers? Can we do something about them? Are shift workers more susceptible to injury when they are off the work site than regular workers? This is not comprehensive in any way, but it's just to give you an indication of the type of information which is required. These are questions that are important to policymakers, and in collecting and manipulating information, we should try to get at these questions. What is record linkage? Well, record linkage, if I give a bit of background before the definition, currently in Canada, we collect data routinely for physician use, hospital use, prescription drug use, workers' compensation data, mortality data. We have large health surveys, social demographic data. We collect population censuses, so on, so on, so on. People think we always measure information about them. However, most of that information is collected in isolation, and it's not integrated in a coherent health information system. It's very difficult to have the full history of one person at one place. However, in order to answer many of the questions I just listed, it is necessary to have information, person-specific, from different sources or from different time points for the same sources. That's what record linkage is all about. And record linkage is the combining of person-specific data from more than one data source. This definition is very broad. And for example, when a chart review is conducted by which data are manually extracted from patient charts in cancer treatment centers and combined with surgical treatment from hospital discharge abstract and mortality data from vital statistics, this could be seen as regular study in clinical practice, but this is effectively doing some type of record linkage, combining information from a person from different data sources. In the context of the healthcare system or the management or health information system in general, record linkage refer to the combining of electronic database together. There are two types of record linkage. The first one is deterministic, and deterministics refer to the case where a common unique identifier is available or are available on two or more files. The information is simply combined by the use of these common identifiers. This is quite easy to do, can be done with many software. For example, an OIP registration number is available on hospital separation files, physician billings, and cancer registry. It is therefore possible to combine the information from these three sources to create a unique database with a common identifier. Some difficulty may happen when one or more of the databases have missing information. In this context, we'll use what is called a hierarchical approach. That is, we try to match first with the best quality identifier, say the OIP numbers. For all non-matches after that step, we'll try another set of identifier, could be exact name and date of birth, and we'll go on until we have exhausted the list of good identifier or until the incremental benefit of adding another step in the hierarchy is not worth doing it. One excellent example of the use of record linkage with unique identifiers is a study by Jack Tu and colleagues published in the 2001 in JAMA, where they studied the relationship between annual income of volume of patients treated by admitting physicians and mortality after acute myocardial infarction. They built a retrospective cohort study using linked administrative databases containing data on hospital patient hospitalization admission and their treating physician. The study showed that patients with AMI who were treated by high-volume admitting physicians were more likely to survive 30 days and 1 year. The result of this study may have an impact on how healthcare services are provided to this patient population. So this is just an example, and you're probably aware ISS do a lot of these work in Ontario by using OIP linked data, and that's very important. There's also another type of linkage when we don't have a common unique identifier. And where's my slide? Okay. So the difficulty in performing okay. So probabilistic linkage is used when there is no common unique identifier on the files to allow the linkage. But there is some identifying information. That identifying information may not always uniquely identify an individual, could be incomplete, and could be subject to errors. This is a much more technically difficult problem to deal with. I will take the next few minutes to provide an overview of how probabilistic record linkage works and use a real-life example to explain the different steps. I'll talk about the Manitoba Census Linkage Project, where the objective was to create, using record linkage, an analytical database for a sample of 20,000 Manitoban households that would include socio-demographic information from the 1986 Census of Population with longitudinally linked health record for the province of Manitoba, which would include hospital visits, physician visits, billing for tests, births and deaths, And the objective is to study the association between socioeconomic status and disability on one hand, and health and healthcare utilization on the other hand. Record linkage was required because the admin data do not contain the socioeconomic status and the disability, and conversely, the census does not contain any healthcare utilization data. The linkage was authorized under the Statistics Act, and it would be done without the use of common identifiers. Names are not captured on the census, so we cannot use the names. The names are not available on the Manitoba health registration file that was used for that specific linkage. As a result, we had to use identifying information such as the postal code, the gender, the month and year of birth, and the family structure. Some assumptions are made when performing probabilistic record linkage. First, there is no combination of common variables that could uniquely identify an individual with certainty. That means there is no common identifier. This is a fundamental difference between exact and probabilistic record linkage. This means that even when two records have exactly the same information on a series of variables, there is no guarantee that it is the same individual. What we have is limited identifying information of individuals on both files, i.e. the census record and the Manitoba healthcare records. This information is incomplete and subject to error. For example, we may have non-response on the census or data entry on Manitoba. It is assumed that the errors on both files are random. So that's the basic conceptual framework for doing the study. To put the files together, we can identify all possible cross-comparison between the census record and the Manitoba record. That is, we compare each variable for each record, and we label them as agreeing or disagreeing on postal code, sex, year of birth, month of birth, and family structure. To determine which cross-comparison correspond to a link, we can associate a value of 1 when the information on a specific variable matches, and 0 otherwise. In this very basic example, the value for each cross-comparison will range from 0, there is no information that agrees on both files, to 5 when they all agree. When the comparison has been completed, we need a rule to separate the matches from the non-matches. It seems obvious that pairs with a value of 0 are non-matches. However, where is the appropriate cutoff for matches? What are the probabilities that one individual from the census that agrees on 4 or 5 characteristics with the Manitoba record represent the same individuals? What are the probabilities that one individual from the census that agrees on 5 out of 5 variables with the Manitoba records represent a different individuals? So, for each possible pattern of paired information, we need to derive 3 and only 3 possibilities. And we'll classify the comparison of records to be either a match, where we have a high confidence that the two records correspond to the same individual, probable, where we aren't sure if the two records correspond to the same individual or not, or a non-match if we have high confidence that the two records are not about the same people. Assigning a value of 1 when the information is the same on two records and 0 otherwise is too simplistic and does not properly reflect the amount of information revealed by a comparison. For example, the probability that an agreement happens randomly on a month of birth is roughly 1 out of 12, while for age, it's roughly 1 of 80, corresponding roughly to the life expectancy. The year of birth discriminates more than the month of birth. As a consequence, matching on year should have more weight in the final, matching on year of birth should have more weight in final decision than matching on month of birth. Furthermore, there is a lot less people aged 85 years old than people aged 45 years old. So matching on a specific value should also have a different weight. In order to do so, we make the use of information theory and define specific weights for each comparison. And I will not go into the algorithm and how it's calculated. I'll just stay at the eye level. So the graph on this slide shows a theoretical representation of the distribution of the total weights for a set of comparisons. Establishing proper cutoff points such that we obtain an optimal partition of the set of all possible partitions is a mixture of science and art. It is highly based on science since the underlying distribution is based on information theory. However, even though there are automatic algorithms to determine cutoff points, in practice, this is an iterative process by which comparisons around the thresholds are manually scrutinized to minimize the misclassification of records into the match and the unmatched groups. In performing record linkages, there are validation steps throughout the process to ensure the quality of the link and consequently the quality of the database that will be used for further analytical purposes. I will not present further theoretical details on record linkage. My objective here is simply to convey to you that there is a very well-established statistical framework under which probabilistic record linkage is done, implying that record linkage can be done without the use of unique identifier. Now, if we come back to the Manitoba census linkage, we had the match rates between the two files of 74% in the household population, 55% in the collective institutions, and 39% in collective non-institutions. We did the manual review of microfilm from the census, and we obtained a copy of names from Manitoba about a sample of match and non-match, and we established that the accuracy in the household component was 95%. So with the algorithm we used, when we concluded automatically that the person was the same on both files, this was true 95% of the time. Due to the small match rate for the collective institutions and the collective non-institutions, we decided to exclude them for any further research project, and they would not be included in the database given the low level of matching and the possibility of a significant bias. So the new database of 48,000 Manitoban, incorporating the detailed questionnaire from the census, which give us the socio-demographic information, with the longitudinally linked Manitoba health data on ambulatory services, hospital services, and entry to nursing home, mortality from vital statistics, and the health and activity limitation survey for a subsample of 4,400 people, effectively allowed to create a rich database to study the association between socioeconomic status and health. Many studies were performed, but I just would like to highlight two results. We effectively, for the first time in Canada, look at socioeconomic gradients of healthcare use during the first year of life using individual level information. The important conclusion we draw here is that there's a significant difference in the use of preventive visits by mother of low socioeconomic status. They use less of them, which is counterbalanced by a higher use of what we could call acute care or hospital visits. The result also was that in terms of cost, women of low education, the kids of the women of low education, use about twice the amount of services in terms of dollars than women of high socioeconomic status. It is unclear if the difference in usage is due to the health state of the kids or if it's due to the reduced use of preventive services by their mother. But this is an area which is quite interesting in terms of understanding the health use of infants based on the education of their mother. But it also points to the fact that when we look at socioeconomic disparities, it seems to start from the start. We also look at life expectancy by education and income quartile, and what we find is a clear gradient. Income is a bigger predictor than education, and this was the first time in Canada that using individual level link data, we effectively were able to document that. A lot of work has been done, specifically by Russell Wilkins, looking at ecological variables, so using people that live in quintiles of areas in Canada, but this was the first time we look at individual level. We will be doing a 10-year mortality follow-up of the 1991 census, which will allow us to calculate many of these disparities indicators for different provinces, for subpopulation, not just by education and income, but occupation and other groups. And this was required to do a record linkage because vital statistics does not contain information on income nor on education. Until now, I have shown you that it's feasible to perform record linkages, even when there is no common unique identifier and no names on the file. The techniques have been developed, software is available, and computers are more and more powerful and allows record linkages to be performed on a desktop computer. I have also presented results of studies that provide policy-relevant information for decision makers. So why talking about record linkage in a lecture like this one? Well, the real issue behind what are the real issue? And the main issue surrounding the use of record linkage is one of privacy. If I just quote a CMA survey, they noted that without consent, 51% of Canadians would not agree to the release of their personal information to government and researchers, even if information could identify them were removed. This percentage effectively increased to 77% when consent has been obtained. So Canadians have some hesitation of having their information used without them knowing that it has been used. And privacy is a relative concept which depends on the individual's value system, perception, the topic under study, and their general culture and beliefs. As it relates to health, health is clearly one of the most intimate and consequently privacy-sensitive topics to study. I just would like to quote a definition of privacy, which is a right recognized by many laws in Canada, provincial and federal laws, and it's our fundamental right as individuals to control information about ourselves, including controlling the collection, use, and disclosure of that information. So on one hand, privacy is a fundamental right in a democratic society. Given that any individual-level study of health-related issues without the explicit informed consent of participants is invading it. Under what authority can record linkages be performed? For which type of studies and for what purpose? Is this right absolute? Well, on the other hand, health is a central value of Canadians, and here are two quotes, one coming from the Canada Health Act and the other one the Canadian Institute of Health Research Act, which effectively the Parliament recognized that health is a central value to Canadians. Okay? There's a third issue that I would like to bring into the perspective, which is one which I would call ethics, but not in the traditional sense, more societal ethics, which has been brought by Jacques Siemiatiki. Don't tell him I pronounce his name like that. And the ethical aspect is that the benefit of medical knowledge that we enjoy today are due to research that has been conducted using information about millions of people in the past, mostly without their being aware that such information has been used. Does our generation have a right to benefit from the past if it is not willing to allow future generations to benefit from our experience? So there seems to be three things. There's privacy, public health, and what should we do as a society, as a generation? What should be the intergenerational transfer of knowledge from one generation to the next? Let me give a real-life example of what I mean by ethics and some research question that should we or should we not address. Vaccination is the greatest public achievement of the 20th century. The safety of MMR vaccine is currently being questioned. There's a lot of press, mainly in the UK, but also in the US, about the possible link between MMR vaccines and some neurological disorders. Some people are questioning that it's the vaccine itself. Some people are questioning that it's maybe the preservative in the vaccines. And some other people are saying that has nothing to do with the vaccine. This is just an artifact of more diagnosis of neurological disorders. We don't know. But the consequences of that is that in some counties in the US, the immunization rate for MMR is below 80%. The World Health Organization considers that for a population to be immune from a disease, a contagious disease, it needs to be at 95%. So the rate is much lower than the 95% target to immunize the population as a whole instead of individual. What should we do about it? Should we stop there and say, well, we can't do anything because we'll have to use individual records? Should we study without letting people knowing that this is being done? Should that be reviewed in some ways? So what researchers are doing is that they're trying to address that question. And a 2001 study published in the New England Journal of Medicine by Berthelot and colleagues used a linked immunization medical record file for close to 700,000 kids to study the impact of febrile seizure resulting from the MMR vaccine and long-term health effects. This study concluded that febrile seizures resulting from the MMR vaccine do not appear to be associated with any long-term adverse consequences. This is one part of the answer to the question, but people are doing something. This study could have not been done without record linkage and without an invasion of individual privacy. Well, health is effectively a public good, and I have to say that the Privacy Act in Canada effectively recognizes this right. So there's a public good aspect of health, there's an individual right, privacy. So the notion of research, and certainly health research, and I won't read this, you can read this, as a public good is effectively recognized explicitly by privacy laws, both at the provincial and at the federal level. This is the excerpt from the Federal Privacy Act. We have the same thing in PIPEDA, and Ontario is currently working on the privacy legislation. And they authorize the disclosure of personal information without consent for research under specific conditions. So what do we need? Well, we need a balance. A balance needs to be achieved between the individual right of privacy and the overall public good. But how do we establish a balance? Who decides when record linkage should go ahead? Who decides when it should not go ahead? What is the process that we should go through? Record linkage presents a greater risk to privacy than prospective data collection for three main reasons. One, it combines information to obtain a more comprehensive view of individuals. Two, by having more information on the individual, it can identify unique behavior at the small area level, creating a risk of identification of individuals which otherwise would not be possible by looking at only one source of information. Three, the combined information can be used after it has been linked for a broad range of reasons other than that for which it was collected. And I could add a fourth one is that in prospective data collection, people can say, no, I don't want to participate. So what should be done is a thorough review process, regardless if it's conducted manually or electronically, if it's with using deterministic record linkage or probabilistic record linkage, a thorough review process should be put in place. And it should cover the different aspects, such as, for public good, what is the purpose of the study? Is it in the public interest to do it? Was the study peer-reviewed before it was approved? To go ahead. Was the study approved by a research ethics board or similar body? Could the result of the study impact negatively on individuals in the study? Privacy. Will informed consent for doing the record linkage be requested? If no, is it for good reasons? And I'm not sure that money or time is a good reason. Will the linked database be anonymous? If no, what's the reason? Will the content of the database limited to the information required to answer the research question? Are the data to be linked covered by any privacy legislation or regulations? If so, does the proposal meet the requirement of these act or legislation? Is record linkage required to conduct the study? Confidentiality and security. How will the access to the data be controlled? How many individuals will have access to the linked database, and do they all need to have access? What security measure will be put in place to protect the confidentiality of the personal information? How long will the linked database be retained? Who will be responsible for destroying the database when the study will be completed? Is there a provision in the proposal to possibly extend the duration of the database? If yes, under what conditions? is a signed pledge of confidentiality required to access the database. In terms of transparency, people want to know what is being done with their data. Who is accountable for this project? Will a summary of the research proposal, including a brief summary of the privacy assessment, be publicly available? Will the database use limited to the research topics of this proposal? Is there a mechanism by which someone can challenge statements made in the privacy assessment documentation? What are the planned means of dissemination? Was there any public input or consultation during the review process? Potential conflicts of interest. Who is financing this project? Is there a risk of conflict of interest? Can anyone gain any commercial or monetary advantage for producing or using this database? Who is owning the dataset? So all of these aspects should be covered, and I guess with my list of questions you see that I think it should be quite thorough. So obviously this is not an exhaustive list, but it provides a good indication of the type of detailed review process that I think should be made. So this concludes the part of my talk that deals with record linkage. So for 2 decades, a great deal of attention has been given to privacy of Canadian citizens. The debate about privacy invasion created some clash of cultures between researchers and privacy advocates. I think that this sometimes heated debate has helped to recognize the value of research as a public good. Privacy Act currently in place in Canada do explicitly recognize the value of research and allow the use of personal information without consent for statistical and research purposes. Also, this debate has forced researchers to become more conscious of the rights of citizens to be left alone. A balance between privacy protection and public good can be achieved in the use of record linkage for health research, when specific mechanisms are put in place to ensure that the proper review process is in place and that concrete steps are put in place to guarantee the security and confidentiality of personal information. So up to now I've talked about record linkage as a statistical technique that allows us to bring into a single database different pieces of information on one individual from different databases. However, sometimes we need to synthesize or bring together information on a specific topic instead. I will now present a summary of work we have done on colorectal cancer screening using a microsimulation model as such a framework. I will not provide any technical background on the microsimulation software. I will focus on the result of the study, but I'll be very pleased to answer any questions specific to the model in the discussion section. Just a bit of background. So colorectal cancer is the second cause of cancer deaths in Canada. We, in 2003, estimated that about 18,000 new cases would be diagnosed and about 8,200 deaths would be identified in colorectal cancer. We also know in colorectal cancer, and here I should point that the right axis is count of population structure. The left axis is the incidence rate per 100,000, so the white line goes with the right axis. This is the wave of the baby boom, so my generation, moving into these years where we'll all get colorectal cancer. Not all, but. So we would expect a large increase of the number of colorectal cancer being diagnosed because of the baby boom moving into the ages where the disease is effectively much more prevalent. Okay, so that's an important context information. We also know from cancer epidemiology that the stage of diagnosis is very important in predicting the survival of cancer patients. This is one example. I think it's rectal cancer. And you see that if you're diagnosed at stage 4, it's not really good. If you're diagnosed at stage 1, this is a much better outcome. So if there's a test that could effectively detect people earlier in the development of their cancer, it may turn out to be effective. So the context, specific context, random controlled trials have shown the efficacy of screening for colorectal cancer with fecal occult blood test, FOBT, combined with colonoscopy. So the test itself works. there was a national committee set up by Health Canada to effectively establish recommendations for colorectal cancer screening in Canada. And the main issue is, what would be the impact of such a screening program in Canada? We know a test works at the individual level. Would it be beneficial at the population level? So the subsequent questions are, what would be the expected mortality reduction under a population-based screening program? What is the most appropriate age range? When should we start screening? When should we stop screening? What would be the cost and resource impact of a screening program? Is it cost effective? How sensitive are the results to the program parameters? So we have used the population health model, which is a framework for organizing health information for a representative sample of synthetic people. It's a computer simulation model which creates synthetic human population and age them while exposing them to risk factors and diseases using computer Monte Carlo simulation techniques. POEM was used to evaluate the potential impact of colorectal cancer screening in Canada. Now I'll just try to visually provide you an indication of what a microsimulation model is. It's interesting. This software was developed in 1991 or 92, and at the time it took 5 minutes to go through just showing what's going on. So in a microsimulation model, the case that I presented here, we would start with a bird cohort, say 1 million people, 2 million people. We would process them one at a time, and we would, at different points during their life, we would draw random numbers and compare these random numbers to known probabilities to make a decision if the outcomes happen or not. So just as a synthetic representation, when we do microsimulation, we start with a blank slate. We're trying to generate effectively the life of a person. So the person was born, age, get to school at age 5, is effectively subject to norms. That person work again, get a new job or out of school, get a job at age 20. That person would effectively have some difficulty or work-related injury due to working in an environment where the air was effectively polluted. That person would lose his job. That person will have a heart attack, which will create costs, go to the hospital. And then that person will live, will have different level of functional health, and will die at 84 after having been looked after by a devoted spouse. So the objective of a microsimulation model is to obtain information on all of these outcomes and integrate it into a conceptual framework and a microsimulation model where we will draw random numbers to effectively generate these events. Okay? Just a little representation. So here I'm just giving a small example about breast cancer. So a woman is age 51. She has age at menarche at age 11, which is a risk factor. Obesity of 29, age at first birth of 33. We would obtain a relative risk based on her risk factor profile. We would have a baseline incidence rate that will multiply the risk factor, the relative risk by, which will give us a probability of incident cases. We'll draw a random number, we'll make a decision. In this case, the woman did not get breast cancer at age 51. We go to the next event. The next event, because this is going a bit fast, but the next event is that she turned 52, risk factor, change obesity. Now she's a BMI of 30, not 29, so her risk is move up. So it's 3.9, the relative risk. The baseline incidence has gone up. Probability of incidence is the product of the relative risk times, I guess it's more the hazard, but that's a representation here. We draw a random number, compare with the random number. Random number is smaller than the probability. That woman gets breast cancer. So that's just a very basic example. What we will be doing for colorectal cancer is a little bit more complex, and we would have information about incidence, and that's where the combining of information from different sources comes into play. So we have the Canadian Cancer Registry that provides age-specific incidence for colon and rectal cancer. We have done a chart review data to obtain information about the stage, the diagnosis tests that are performed, and the treatment for people with colon and rectal cancer. It's also used to look at disease progression, so we build a longitudinal data from the chart abstraction. In terms of looking at what are the follow-up frequency and practice, we use the Manitoba link database of health services with a questionnaire to oncologists, and we obtain direct costs from the Ontario Health Insurance Plan, National Length of Stay data, and Ontario Case Costing Project. These are all the information that we use to build a baseline colorectal cancer model. And above that, we did add a screening component where we effectively use the result of clinical trials. The main one is the Funen clinical trial in Denmark, the Nottingham clinical trial in the UK, and the Minnesota clinical trial, all specifically doing work on population-based colorectal cancer screening. So we put all of that together, and then we try to answer the question, and that's what I'll focus on. So we look at, in terms of outcome that were relevant to the Canadian panel, we look at the 10-year mortality reduction, 25 years, number of deaths avoided, deaths due to complication, because there are complications to do a colonoscopy after an FOBT. We look at different parameters of the screening program, biennial or annual, with a 67% participation rate or a 50% participation rate. In summary, if we look at what is the target, the first column of results, which is the target rate, it's about a 17% reduction of colorectal cancer deaths after 10 years, 14% after 25 years. If you apply that to the Canadian population, it would mean roughly 24,000 colorectal cancer deaths avoided. Doesn't mean people don't die of other things. And 133 complications. We estimated the cost of the screening program in terms of physician visits, follow-up consultation, investigation, head office, and promotion, and the FOBT kit itself and its processing. It is estimated that it would add about $112 million per year on average, discounted at 5%. And that includes the reduction of treatment cost, because if some people are diagnosed in stage 1 or much earlier than they should have been diagnosed, without a screening program, there would be some savings in terms of the treatment cost or the palliative care cost if we avoid deaths from colorectal cancer. It would represent, or it is estimated to represent, about a third of the current cost of treating colorectal cancer in Canada, and it would increase the total demand for colonoscopy by at least 15%. If we look at that in terms of population impact, what we find is that it would increase the life expectancy of the population by 0.04 years, so 15 days. And it would be cost effective at about $6,000 with the core scenario, and if we modify a bit the cost and increase them, $10,000 for the biennial screening, which is the core, and you see how the results vary based on some sensitivity analysis. We also look at what age should the screening program be implemented, and we did incremental cost-benefit analysis. And it looked at starting at age 40 instead of 45 would increase the cost but not produce much benefit. So the underlying incidence is not large enough in that age group. That's the main driver. Starting at age 45 versus 50, while this is maybe cost effective, many people have used a threshold of $40,000 per life year saved to be a cost effective intervention. However, starting at age 50 seems to be effective. We did also look at the impact on the life years gain, and we find roughly the same results. We did the same thing to look at when they should stop the screening program, and it looks at age 70 or 75 seems to be appropriate. We also look at, because when you do a screening program, you need to provide information to people. And when they are enrolled into the screening program, you make the assumption that they will participate for all the screen. They will be invited and they will participate at all the screens. So you need to tell them what is the expected or estimated consequences. So if a person, 50-year-old, participates fully in the program, all the invitation, he says yes. If there's a positive FOBT, he will say yes to the colonoscopy. We expect that there will be a mortality reduction from colorectal cancer of 35% after 10 years and 30% after 25 years. The gain in life expectancy will be about 37 days. And for the one who were deemed to have colorectal cancer, which we don't know, which are the only one that would benefit from this intervention, it would increase the life expectancy by a bit less than 2 years. A quarter of them will go through colonoscopy. Oops, this is moving along. And the lifetime probability of complication would be not much for death, perforation a bit bigger, and hemorrhages quite small. But these are non-zero probabilities, and you should inform the people who would be participating in the screening program. So as a summary of that work, the participation rate is the major driver of mortality reduction for colorectal cancer. And there's a question about the real participation rate in Canada. Cancer Care Ontario have established, since the release of the national report, a screening program, I think, which started in July, or they were implementing it. I don't know if it's now running, but they are doing a pilot test to collect more information about participation rate and other aspects of a screening program. The age group 50 to 74 seems to be a good target age group. And the annual and biennial FOBT screening were both cost-effective. However, the annual screening would double the number of colonoscopies and FOBTs and would create a much bigger stress on the limited resources. Limitations: computer model is not reality, it's a computer model. It highly depends on the assumption used to build the model. In this case, there was a subcommittee of experts that provide us with the information about the type of test, the participation rate, clinical trial data that they point us to the proper clinical trial data, and sometimes we're limited also to have to use information from specific province or region to build a full model. Such a model is difficult to validate. In our case, what we did is we reproduced the result of the Funan clinical trials, but the model is a model. It's always wrong. But when you have to make decisions, I think you have to get the best possible information to make the decision. And I think Yogi Berra summarized everything. I think Yogi Berra was a star in microsimulation model, right? And in the use for policymakers. So I guess you know who Yogi Berra is? Well, not the front row, I want the back row. You don't know who Yogi Berra is? Well, I'll say his quote and then I'll say who he is. So it's tough to make predictions, especially about the future. Yogi Berra was a star baseball catcher in the 50s and probably the 60s. And then he became a star also baseball coach. But he's now renowned really for his specific quotes. So this was one of the quotes he made when he was a coach, and they were asking him about what is the next game in the World Series, and he said, well, you know, it is tough to make predictions, especially about the future. So thank you very much, and I hope you enjoy it, and open to questions.